Hello you guys, and welcome back. Today we will be covering the vasculature and the innervation of the heart. So the heart is mostly supplied by the right and left coronary artery, and they communicate with each other under the myocardium through the myocardial bridge, and the arteries are going to be embedded in the subepicardial fascia, and that's usually just adipose tissue and some kind of loose connective tissue. The right coronary artery arises from the right aortic sinus of the ascending aorta, and it lies right between the auricle of the right atrium and the pulmonary tree, or trunk. This picture doesn't show the auricle, but the auricle is like a little flap, and it lies right on top of the right atrium. So it is important to know that the right coronary artery runs down in the front of the heart through the atrioventricular sulcus, and it curves around and it anastomoses with the left coronary artery in the back in the posterior interventricular groove. So front is going to be atrioventricular sulcus, and in the back is the interventricular groove. It's really important to know the pathways of these right and left coronary arteries, because that's usually where a ischemic attack occurs, because these are the larger arteries. So it runs from the sternocostal, so the sternum / ribs in the front, to the diaphragmatic surface. So remember, the heart is resting on the diaphragm in a 3D structure, so posteriorly it's going to be kind of like lying horizontal. And then there is a branch called the right conus artery, and that supplies the pulmonary cone, also known as the infundibulum of the right atrium. So the right coronary artery has these branches. It has the posterior descending branch, which goes down more towards the apex, and then the right marginal branch in the front, and it goes also down to the apex, but this time in the anterior of the heart. So the right conus artery, along with the anterior ventricular branch, are going to be branches of the right coronary artery, and the marginal branch is going to be the largest. So the right marginal branch is easily identified because it runs like almost parallel with the curvature of the ventricle. The posterior are going to run also in the posterior interventricular sulcus, like I said. And then there's a bunch of septal branches coming off of the posterior ventricular branches, and those are also the anterior lateral posterior branches, and those are going to supply the atrioventricular node along with the septum in the heart. So the septal branches, of course, pierces the septum. And more importantly, just know that they pierce the septum and supply the atrioventricular node. So in some of the population, the SA node is supplied by the left coronary artery instead. Somewhat important to know, especially if you want to go into heart surgery, to know which side is going to be, supplying the AV node in order to preserve the blood supply, along with tying off the vessels just in case you need to operate on it. And then the atrial branches will, of course, supply the atrium, but it supplies both of the right and left atria. So the left coronary artery is going to be the main artery of the heart. It's going to supply the majority of the heart, and it comes from the left aortic sinus, so in between the pulmonary trunk and the left auricle instead. So it kind of curves around the pulmonary trunk from the aorta. In between right here should be like the left auricle. The anterior interventricular branch supplies all of the apex of the heart, and its left diagonal branch, or left anterior descending branch, is going to be the largest branch. And they also have the left conus artery along with the atrial branches. So this runs down the interventricular groove in the front, And then the circumflex artery curves around, as you see, the back of the heart, and that gives off a left marginal branch, and that supplies the left ventricle wall. So your left coronary artery descends down the ventricles, and it gives off the circumflex, which curves around the back and supplies the left ventricle, and then the anterior and posterior branches of the circumflex branch will supply the left ventricle itself, and the left coronary artery supplies just a larger area than the right coronary artery. And there are some diagonal branches, you can see, but this is the only one that really reaches the true apex of the heart. The anterior interventricular branch supplies the entire apex. In some people, there is some variation. Mostly for most of the population, it's going to be right dominance, where the posterior interventricular branch is the larger branch of the right coronary artery. And the left dominance is rare, and it's going to be a branch of the left circumflex coronary artery. Codominance, it's really, really rare. So there are some anastomosis in the heart, but there isn't really any physiological function for them. As you can see here through the injections, this is going to be the right coronary artery, and see it only supplies here, and the left coronary arteries, as you can see here, this is the diagonal branch, the anterior descending branch. Here's the circumflex. See how is it curving around? But there isn't any mix. This is yellow, this is red. There's not any orange in the middle at all. So this is important because in heart attacks, if there's a big blockage of, let's say, the anterior descending branch, it's going to block off all of the muscles here. It's going to be ischemic, and there's no compensation from the right coronary artery. So here is the arterial supply of the nodes. Sinoatrial nodes for most people come from the right coronary artery. And here's the atrioventricular nodes, also mostly from the right coronary artery. The right bundle branch is going to have the septal branches from the left anterior descending branch, and sometimes there's some collateral depending on which one is dominant, but usually the right coronary artery is going to be the dominant one. Bundle of His, usually from the right coronary arteries. Left bundle branch supplied somewhat by the left side, but posterior and anterior fascicles, of the ventricular walls, are mostly going to be provided by the left coronary artery. So plaques are made out of fats and triglycerides and just molecular waste, and it can be pretty large actually and cause a lot of flow obstruction. There's going to be usually a lipid core. And it's problematic because if it blocks everything off, it leads to ischemia, and also leads to loss of power because power of contraction in other muscles, because the muscles just aren't having enough blood flow. Angina pectoris is going to be chest pain, and it's usually pain on exertion, and it's due to the substantial narrowing due to the spasms. And this kind of chest pain is relieved once the person sits down and rests. A myocardial infarction is the medical terminology for a heart attack, and that is a complete artery block from thrombi. It causes a lot of pain, and it can be reversed if you treat it very quickly. In the heart, the way we treat it is by using an artery or a bypass in order to bypass the blocked part of the artery. Usually you use a vein, the saphenous vein, because it's large and it's easily harvested. You can also use the radial and thoracic veins too. But in general, it's more preferable to use an artery because we don't have to worry about the valves. If you use the saphenous vein, you have to make absolutely sure you put it in right. Otherwise, else the veins or the valves are going to obstruct the flow of blood, and you haven't done anything by doing a bypass. It's important to make sure that you use you use the vein upside down so the valves can allow the flow of blood to the heart. So angioplasty is usually used in order, like in cases where the plaque is not too severe and it is going to be in balloon wrapped around in wire and threaded and minimally invasive, really, through the groin, usually the femoral artery, all the way up, femoral vein to the heart, and then femoral or radial artery, radial in the arm, but usually it's through the leg, the femoral artery, and you widen the vessels just by pressing it against the vessel. You can't just do that by itself because it'll come back, so you use a stent, and it could be metal or drug-eluting. Usually this drug is some kind of like anti-coagulation drug, anti-thrombotic drug, and the scraping out of the plaque is temporary because plaques can come back, but it is used in cases where and the flow is blocked and it's about like 80% occluded. The patient has to be on anticoagulations after operation, and it's usually for a long time, like maybe like 6 months to a year, depending on the age. The heart is usually drained by like the coronary veins that accompany the coronary arteries, and they all drain into the right atrium through something called the coronary sinus. The great cardiac vein will follow in the left anterior atrioventricular sulcus. So it's like a huge sulcus right here, as you can see here, and then it goes right into the coronary sinus. Here's the anterior of the heart, so it kind of curves around and then dumps into the right atrium in the back. And the middle cardiac vein will follow through the posterior interventricular sulcus. And remember, in the posterior sulcus, there's going to be the right coronary artery, the right circumflex branch. And small cardiac veins will also, drain the heart. And the remainder of the blood is going to be returned to the right atrium by the anterior cardiac vein. So whatever has not been drained by the posterior and the middle, it's going to be drained by the anterior and the small cardiac veins. So it's innervated by the cardiac plexus, which is composed of the vagus nerve along with the sympathetic trunks. Important to know that the main nerves, the depressor cordis nerve, that's the superior parasympathetic nerve, and the thoracic vagal cardiac nerves are going to be the thoracic parasympathetic nerves. There's trunks, and those are usually sympathetic, and the ganglia is located posteriorly to the ascending aorta. And the postganglionic fibers will terminate on the sinoatrial and atrioventricular nodes, and pain impulses are going to follow the sympathetic pathway. The afferent fiber running with the vagus nerve is a part of the cardiovascular reflex. What is that? The cardiovascular reflex is how the heart compensates whenever there's a rise in blood pressure, rise in stressors, and rise in parasympathetic innervation. So it's going to respond to stimuli. As you can see here, parasympathetic is going to be the vagal pathway, and that's also connected to the blood vessels. The sympathetic pathway, as you can see here, and it's going to synapse onto the the spinal cord, rather than this parasympathetic, which synapse right immediately onto the medulla. Cardiac pain, it's important to rule out acid reflux, because usually it is acid reflux, not just, a heart attack. And it's referred usually in the upper kind of neck, back area. There's going to be some numbness in the left chest and shoulder, over the shoulder to the scapula, so it goes all the way back. And then in the elderly, it can be referred down to the stomach, and that's important to note. Okay, so the apex is going to be in the fifth intercostal space, and the tricuspid valve is going to be behind the right half of the sternum, opposite from the fourth cartilage, so right here. And the aortic valve is going to be behind the sternum, opposite of the third intercostal space. We need to know, like, kind of like where the apex is in the bare area, once again, so for like a pericardiocentesis. Auscultation. Lub is the sound where the blood hits the tricuspid and the mitral valve. Dub is going to be when the blood hits the aortic and pulmonary valve when they close. And you want to listen in a zigzag, so you start with on the left side to listen to the aortic sounds, so right, like kind of down from the angle of Lewis. So you go from A, P, pulmonic to Erb's point, to the tricuspid, to the mitral, to hear the mitral sounds. And I remember it's just like a pet, so across and down. Okay, so we use radiology, so x-rays, to see if there's any fluid surrounding the lungs, or heart, and you use a coronography to see a blockage, as you can see here. Here's some blockages right here. Bad. And if you remember, this is going to be the left branch. So this is the left descending, anterior descending branch. This is going to be the left circumflex, as you can see, it's carving around. So bad stuff. ECG and EKGs are also used usually to see if anything's wrong with the PQRST, like, spikes. And then you also use, an ultrasound to see if there's any blockages and to see if there's any, like, cardiac tamponade happening. Valvular disease. It can be genetic, and it can be part of, like, poor lifestyle. Atherosclerotic plaques can lodge into them or attach to the valves and cause problems. And some illnesses will cause the inflammation of the valves, and it causes the edges of the cusp to stick together. And then fibrous thickening occurs and make the valves really stiff, so they don't close as nicely anymore. You can hear that during your heart examination. You hear a murmur or regurgitation, and you usually fix it with valvuloplasty, angioplasty. In some cases, it's the chordae tendineae that's damaged, so you use a chordoplasty, like up here. You're just going to attach a ring around the valves itself, and then suture the chordae tendineae to the artificial ring. So you also use like a balloon to put in a replacement valve, as you can see here. Here is the aortic valve, anterior leaflet, and you suture it like right here. And sometimes, in rare occasions, you replace the valve entirely. And nowadays, it's pretty minimally invasive. There's not like open heart surgery anymore. As you can see here, this is just going to be like a balloon stent put in. Okay, that's it for now. Thank you for your attention, and good luck studying.